Very good morning. This is Dr. Kruthika, Associate Professor from the Department of Pediatric and Preventive Dentistry. Today, we'll be learning about avulsion. So, what do we know about avulsion? Avulsion is nothing but when the tooth is popped out of the socket. When the tooth is completely displaced out of the socket, then we call it as avulsion. As per the definition, avulsion implies to the total or complete displacement of the tooth out of the socket. Avulsion is otherwise called as total luxation, exarticulation, or according to the Ellis classification of traumatic injuries, avulsion falls under Ellis class 5 fracture. In general, the tooth is held in the socket by the periodontal ligament fibers. When there is an injury to the periodontal ligament, then it goes for avulsion. When there is a blow, when there is a hit which causes injury to the periodontal ligament, then the tooth becomes mobile and it pops out of the socket. This is called as avulsion. I have a video for you to show how an avulsion occurs. Yes.
Avulsion occurs when a tooth is completely displaced from its socket or knocked out. This often occurs as the result of trauma or impact to the face and mouth. Normally, your tooth is held within the socket by what is called the periodontal ligament. When a tooth is knocked out, this connection is torn loose. Typically, the empty socket will fill with coagulant as a natural response to the injury. Oftentimes, your doctor will take a series of x-rays of the area while diagnosing the injury to verify additional damage beyond what is visible has not occurred. It is important to seek treatment for an avulsed tooth immediately to provide the best likelihood that your doctor can preserve your tooth. Your doctor will discuss options with you that provide the best possible outcome.
So hope it's clear that how an avulsion takes place. We'll go back to the slides again. So when there is an injury to the periodontal ligament, the tooth falls out. That's called as avulsion. Because the tooth is out of the socket, now the body will automatically react. So what happens to the socket? The socket gets filled up with the blood or it forms collagen. Okay. So when we inspect the patient, we need to take utmost care to inspect the alveolar socket as well. Look for its intactness because our treatment plan is going to be based upon the intactness of the alveolar socket. All right. So if a patient calls you and says he has got the tooth out of the socket, then what will be our reaction? Our first and foremost instruction to the patient is to make sure that they are not panicked. Ask them to calm down, relax. Once they are relaxed, then ask them to go and search for the tooth which has popped out of the socket. Once they find the teeth, ask them to hold the tooth in the crown portion and rinse it under running water. Make sure they don't scrub or scrape the root surface. They're supposed to handle the tooth only in the coronal portion and should not touch the root portion. And also ensure that they don't use soap or alcohol. If possible, ask the patient to insert the tooth back into the socket. If they're apprehensive and doesn't want to do that, then ask them to bring the tooth immediately within 30 minutes to your clinic, taking the tooth in a proper storage medium. Ask them to put the tooth in a milk which is readily available in the home and place it in a container and ask them to rush to your clinic within half an hour. Why half an hour? Because this is the golden time which is going to determine the prognosis of the tooth and its treatment. All right. Next, once a patient comes to your clinic, you quickly assess the general status of the patient. Ask for their medical history. Ask for their various problems if they have any. And then, before you start with the examination, ensure that you mark down the time on which the trauma has taken place and the time lapsed since injury to the time when they reported to your clinic. That is the crucial time based on which you're going to determine your treatment. And also make sure that enter the place on which the trauma has taken place, and also note down the medium in which they brought the tooth, whether it's wet, whether it's in a milk or any other medium, or they have brought it in a paper, or they have brought it dry. Please note it down. So once fastly you have taken your history, you will start ahead with your clinical examination. Now examine the tooth which they have brought. Look for the stage of root development, which is very important. Check for the cleanliness of the tooth. If there is any visible dirt attached to the root portion, cleanse it properly by showing the tooth in the running water. Once you have examined the tooth, then examine the socket. Check if there is any periodontal disease. If there is any presence of periodontal disease, then your success of the treatment is going to be very less. And also ensure that the alveolar socket is intact. Make sure there is no alveolar socket fracture. Once you have examined the socket, then go ahead with reimplantation. What is reimplantation? This is nothing but a technique in which the tooth is reinserted into the socket. It's as simple as that. Try pushing the teeth back into the socket by gentle pressure. Before you reinsert the tooth into the socket, ensure that you irrigate the socket completely by using saline, so that there is no blood clot, there is no clogging, there is no obstruction for the teeth to get reinserted. Once you've irrigated the socket, then try reinserting the tooth with light pressure. But there are certain few contraindications where you're not supposed to reinsert the tooth. While you're taking the medical history, ensure that the patient is not an immunocompromised patient. He doesn't have any severe congenital cardiac anomalies. Patient does not have uncontrolled seizure disorders, and also patient is not mentally disturbed, and ensure that he is not having any uncontrolled diabetes, because these are the conditions which are going to affect the prognosis of the treatment. In case of uncontrolled diabetes, the healing is going to be delayed, which will in turn affect the prognosis. And also in cases where there is immunocompromise, then the patient will go for septic infections, so the prognosis gets delayed. So preferably ensure that the patient doesn't have all these complications. Once you're sure that the patient is not falling under any of this contraindication, then start the factors which will determine your treatment plan. Now, a treatment of the Avils tooth is based upon the root and formation, the time that is lapsed between the injury and the time they reported to the clinic, and the medium in which they are placed. The three important factors are the root development, whether the root is completely formed or not. And the second is the time lapsed from the injury till they reported to the clinic. The third one is the medium in which they brought the Avils teeth. So all these three are going to determine the treatment. So the first one, treatment of avulsion, apex, which is the root information, whether the root is completely formed, which means the tooth is a mature tooth, the apex is closed, or there can be an immature teeth or an young permanent teeth where the apex is open. And the next thing is, the second point, what I said was the extra oral medium in which the tooth is being brought, whether it's brought in a wet storage medium or it is brought dry. And the third is the time that lapsed between the injury to the time they reported the clinic. The first one is whether they reported immediately, that is less than 15 minutes of the injury. Next is 15 to 6 hours if they have brought the tooth in a physiological medium. Usually the physiological medium includes the Hank's balance salt solution and the milk. And the third one is 15 minutes to 2 hours if the tooth is stored in a non-physiological medium. That includes all other except HPSs and milk, which includes your saline, your tap water, your contact eye solutions, coconut water, tap water. All this falls under non-physiological medium. These are wet mediums. That means the tooth is stored in some liquid mediums. And the next one is dry storage, which means the tooth is not placed in any liquid. They have brought it in a paper or in a pocket or just brought it in their hand. if they have brought it within 60 minutes, it is less than 1 hour, or if they have brought it more than 1 hour. These are the 5 things which will determine your treatment plan. So first we will look into these 5 conditions in case of an open apex teeth. If the avulsed tooth is an open apex teeth, and if the patient has reported immediately, that is less than 15 minutes to your clinic, then you don't have to panic. It's just as simple as that. Just reimplant the tooth and reposition it in the socket. That's it. Just clean the socket, irrigate, look for the cleanliness of the root surface. Everything is fine. Then reinsert and reposition it in back into the tooth. Next is, if the patient has stored the teeth in a physiological medium, that is either HBSS or milk, and they have rushed to your clinic within 6 hours, 15 minutes to 6 hours, if it is stored in a physiological medium and they have reported to your clinic within 6 hours, then just soak the tooth in 1% doxycycline, which is an antibiotic, for 5 minutes, and then reposition or and reimplant the teeth in the socket. Or if the patient doesn't know about the physiological mediums, they have just stored it in a tap water and they have reported within 120 minutes, that is within 2 hours, if they have reported to your clinic stored in water or any other medium, then immediately change the tooth to a physiological medium, that is HPSS. Once you have transferred it to HPSS, leave it for 5 minutes and then reposition it. And the fourth scenario, they have brought the tooth dry, which means no wet medium is being used. They have just brought it dry, but they have reported within 1 hour. Then the same process of dropping the tooth back into the socket, back into the HPSS solution, and then reimplant and reposition the tooth. If the patient is reporting with the tooth in the dry storage medium and they have reported more than 16 minutes, that is they have reported only after 1 hour, then we don't have the chance of survival of the periodontal ligament cells. Then what we have to do is just soak the tooth in citric acid for 3 minutes, then rinse well and scrape the root surface to remove the PDL cells by using a scaler. After removing the PDL cells from the root surface by using a scaler, place it in a sodium fluoride for 20 minutes. Then after 20 minutes, reimplant and reposition the tooth in the socket. So there are 5 scenarios based upon the time and based upon the medium. So once you have reimplant or reposition, then verify the tooth position by using an IOPA. Then place the tooth in position and splint it by using a flexible splint. Then start with the antibiotic, give postoperative instructions, preferably advise the patient to take tetanus toxoid injection, and then ask the patient to come back after 7 to 10 days. This is the first follow-up where you need to start your apexification or apexogenesis based upon the vitality of the. Since it is an open apex, we attempt for apexification or apexogenesis. So now we have understood the treatment plan of an avulsed tooth with an open apex. If the patient reports with an avulsed tooth which has a closed apex, then all 5 scenarios will be coupled together to form 3 basic scenarios. The first 2 scenarios, which is if the patient is immediately reporting, that is less than 15 minutes, or if the patient is reporting to your clinic in 6 hours, but provided they have stored the tooth in a physiological medium, that is your milk or HPSS, then since it is a closed apex, you can replant the tooth immediately. Or if the patient is reporting in a non-physiological medium within 2 hours, or if the patient is bringing the tooth dry within 1 hour, then you need to transfer it to the HBSS, which is the physiological medium, and then reimplant it. If the patient is bringing the tooth dry more than 60 minutes to your clinic, then the same as your open apex treatment plan applies. Put the tooth in the citric acid for 3 minutes, rinse well, remove the debris and the PDL cells from the root surface by using a scaler. After that, place it in the sodium fluoride for 20 minutes, and then after 20 minutes, reimplant the tooth. Once you are done with reimplantation, verify the position, place a flexible splint, start with your antibiotic, and then give postoperative instructions. advise tetanus toxoid injection, and recall the patient after 7 to 10 days, which is your first visit. Since it's in closed apex, we'll be starting with the root canal therapy. These are the basic treatment plans for the owl's tooth based upon the conditions. So after 1 week, we'll start with your root canal, being it an closed apex, root canal, if it's an open apex, apexogenesis or apexification. After that, follow-up has to be for 1 month, 3 months, 6 months, 12 months, and then visits has to be per year. This is basically to check the prognosis of the tooth. The prognosis of the tooth is basically determined based upon the extraoral period. That is the time lapse from the injury to the time they report to the clinic, and also the medium in which they have brought. The most foremost importance based upon the prognosis is by preserving the PDL cells. This can be done by delicately handling the tooth and placing the tooth in a proper medium so that the viability of the PDL cells are preserved, and also by appropriate stabilization, that is your splinting. So now I often use a word called splinting. What do you mean by splinting? Splinting is a rigid or a flexible device or a compound which is used to support, protect, or immobilize teeth which has been loosened, reimplanted, fractured, or subjected to certain endodontical surgery procedures. See, when you have a fracture of your limb, you have two people adjacent standing near you, supporting you to walk. The same procedure. When a tooth is avulsed, you take the support of the adjacent teeth and you try to stabilize the tooth in position. This is called splinting. Why is it done? It's basically done to stabilize the tooth, prevent further injuries, and the periodontal ligament fibers will be regenerated. There are three types of splinting, which is flexible splint, semi-rigid, and rigid. Flexible splints are the ones which will help the tooth to have mobility more than that of a non-injured tooth, which is more than the physiological tooth mobility. Semi-rigid is equal to the physiological tooth mobility, whereas rigid splinting will allow mobility less than that of the physiological mobility. So we'll see the various types of splinting. The first one is composite or acrylic resin and arch wire splinting. We have other splinting coming in the next slides. First, for the composite or acrylic resin, I have a video which I would like you to see. I'll stop sharing the slides and I'll connect it to the video. Yes, a video on composite and wire splint.
On the screen, you can see a selection of materials and instruments that you may find useful in making this procedure. In the video, we are assuming that the upper right central incisor has experienced trauma.
The tooth is reinserted.
0.5 to 0.7 millimeters stainless steel soft wire. Cover safely hold both ends. Those of the loose wire in the sharp end of the knife. Place symmetrical safe end loops at either end of the wire with coil forms. This will prevent accident.
Make a small loop on either sides of the wire so that it doesn't injure the soft tissues.
Form a safety handle using coil forms. Bend the wire 1/3 from the medial end at a 90-degree angle to the distal loop. Holding the safety handle, position the distal safe end of the loop on the upper right lateral incisor. Curve the wire to match that of the arch form from the upper right lateral incisor to the upper left central incisor.
Then now the wire is bent to adapt to the contour of the tooth.
Safe end loop split to from the upper left. Use coil forming again to form a loop at this point.
They're trying to give an extra support on the avulsed tooth.
Test the splint against the teeth. If you are happy with this splint, safely cut the wire at the mesial loop, holding both parts of the cut tight into the dispose of the safety handle in the sharp splint. From this point on, it is useful if we hold the splint with a locking string. Splinters are welds are ideal for this. It is now time to place the splint on. Isolate the teeth with cotton walls and dry. Edge and bond the labial surface where the splint is.
Now they're trying to etch the tooth surface. Once etching is done, bonding agent is applied. It's cured. The bonding agent is cured now.
To fill the splint correctly, sides are adjusted by placing small balls of composite on the middle labial surface of the teeth. Start with the mesial and distal end of the upper left central incisor and upper right lateral incisor, respectively.
They're placing the composite over the teeth and the wire is placed over the composite.
Side into the composite.
The composite is added even over the wire and it's been cured for the stabilization of the wire. Now the avulsed teeth is being supported by the adjacent teeth.
Apply composite to the traumatized upper right central incisor, and again, light cure. This will secure the tooth to the wire.
Now the traumatized teeth is being taking support from the adjacent two teeth and it's stabilized. Now we'll go back to the slides. Yes. So the next one, as we saw, is for the first one, which we saw is composite with an acrylic or an acrylic resin, and it's supported with an arch wire. And the next one we'll see is proximal composite or acrylic resin. This is a quick and easy way. The basic thing is you etch the surface of the affected teeth and the adjacent tooth, place the composite in the embrasure region, and then cure it. The disadvantage of technique is that it might injure or it might abrade the enamel surface while you're removing the composite. And the next thing is the procedure where you place composite or acrylic and you stabilize the tooth by using a nylon monofilament suture. These are used instead of a flexible wire. A very short length of nylon monofilament sutures is being used. I have a video for it which will help you understand. The most commonly used brand for nylon monofilament is Ribbon. We'll see the video as well.
Blood and
Yeah.
debris. Place the tooth into the clean alveolar socket. Cut a length of floss that extends 3/4 of a tooth on either side of the avulsed tooth. You will use this floss to measure the splinting material.
They're using a floss to measure the amount of material that is needed to stabilize the teeth.
Use the cut floss to measure the ribbon splint material to length. Do not handle the ribbon directly with gloved hands. Cut the ribbon with the scissors included in the kit. Remove the cap from the acid etchant syringe and place a dispenser tip securely on the syringe. Dispense some material outside of the mouth so as to clear any blockage. Then apply etchant to the reimplanted tooth and the teeth on either side as demonstrated.
So as we have already seen in the acrylic wire splint, they are placing an acid etching material to etch the tooth surface. They're etching the avulsed teeth as well as the teeth adjacent to the avulsed teeth. So once the etching is over, they will apply the bonding agent. Now the etching material is thoroughly cleansed.
Then rinse the teeth thoroughly with water to completely remove. Use compressed air to dry the teeth, which will take on a chalky white appearance if properly etched.
Now then adhesive is applied both onto the tooth as well as onto the rib bond.
Remove an octagon solar capsule from its envelope and twist off the lid to expose the bonding agent inside.
This is the bonding agent.
Clean microbrush into the bonding agent and apply it to the etched tooth surfaces. Avoid flowing the material between adjacent teeth if possible. While holding the ribbon splint with cotton pliers, apply bonding agent to both sides using the microbrush. On the teeth to the curing.
Then they are curing the adhesive material along with the rib bond. Now over the rib bond, they are applying the composite resin for the stemplization. So we'll go back to the slides now. Yes. So that's how they use the composite or acrylic nylon monofilament suture. This is very flexible and easily adaptable. So we can also use orthodontic brackets with sectional wires. The edgewise or straight arch wires can be used with light wires, which will give us flexible splinting. And we also have vacuum formed splints which do not offer sufficient support. For this, you need an accurate impression and lab facility to fabricate. You need to send the impression to the lab where they will make you a vacuum formed splint, and that has to be placed on the oral cavity. Next is suture splint. These are very fragile splints which can be used only for a shorter period of time. A suture is placed over the incisal edge from the palatal or the lingual gingiva, which extends to the buccal gingiva. This is not much effective. And the next splinting technique is arch bar splint, where a metal arch bar is bent and is attached to the teeth by using separate ligatures. This is commonly used for fixation of the maxilla or mandible and also in cases of luxated teeth. The disadvantage of this technique is that since it is in very close proximity to the gingiva, there are more chances of bacterial invasion into the wound. The latest splinting method is titanium trauma splint, where they use pure titanium of 0.2 mm thickness or 2.8 mm width. It is easy to get adapted to the dental arch. Because of its unique rhomboid mesh structure, this is more flexible in all dimensions, and it also allows the physiological tooth mobility without transferring much of the orthodontic forces to the splinter teeth. So now titanium trauma splints are commonly used. So far, we have seen splints for the permanent dentition. Now we need to know a splint for the primary dentition. The splint for the primary dentition that we commonly use is cap splint. Splinting like your permanent dentition is not possible in a primary dentition because of the lack of cooperation from the patient. And cap splint is commonly used in case of alveolar or mandibular fractures. This cap splint is generally cemented onto the non-injurious teeth, and the injured teeth are being preserved so that it does not cause much mobility when you try to remove the cap splint. So that's where a cap splint works. So usually for an avulse dentition or avulse teeth, we go ahead with a semi-rigid or a flexible splint, and we splint it for 7 to 10 days. So this is the common protocol we follow for splinting for avulse teeth. So post-operative instructions, as we all know, we have to advise the patient to take soft diet, and patient has to take liquid food to avoid dehydration, and ask the patient to maintain good oral hygiene, and the patient has to goggle the mouth by using chlorhexidine for twice a day for a week at least, and we will be prescribing antibiotic and painkillers, and also inform the patient about the possible complication and the pathosis which can occur following the injury. These are the common postoperative instructions we give to the patients with avulsion. So far we have discussed so much about the transporting medium or a storage medium, HBSS, milk, that, this. So we'll see the various storage medium in which the avulsed teeth can be stored. The first one is HBSS. We'll see what it is. Before going to the proper storage mediums, we need to know the ideal requisites of a storage medium. It should be easily available, and the most important thing is it has to preserve the viability of the periodontal ligament cells, because these are the ones which are going to help the avulsed teeth get in contact, come back into position like your physiological teeth, because the connection has to be made by only by using a PDL cells, and the pH has to be similar to that of the oral environment, somewhere between 7.2 to 7.4, osmolality between 290 to 330, and it also should avoid the mitosis, that is cell division of the PDL cells which are actually viable and form clones, and it should also prevent the adherence of osteoclast. If the osteoclast gets adhered, it will cause resorption, so it should prevent that. And the most important thing is it has to maintain the functional capacity of the viable cells. So these are the common requisites of an ideal storage medium. And coming to the container in which they carry, usually the avulsed teeth has to be transported in an unbreakable, non-toxic, leak-proofing, and safe to handle containers. And preferably the inner walls of the container has to be lined with a soft, resilient, sterile material so that the tooth is protected when they are being transported. The first one is Hank's balanced salt solution. This is considered to be the most suitable storage medium because the pH is somewhere between close to the 7.2, which is similar to the oral cavity. And this does not require refrigeration. And the shelf life is about 2 hours, so that it can be preserved for 2 years. And the most important, and which makes HPS as a physiological medium, is that it preserves the viability, mitogenicity, and clonogenicity of the pedial cell, which is very important for the success of the avulsed teeth. And it also helps in regeneration of the PDL cells. That's why HPSS is considered to be a physiological storage medium. It's commonly available as saver tooth. And next is milk. It's very commonly available. It has the nutritional proteins, growth factors, and favorable pH and molality close to that of the oral environment. Preferably use the milk being pasteurized, because pasteurization will help in diminishing the bacterial count, and it also causes the inactiveness of the enzymes which are harmful to the PDL cells. When the tooth is being stored in the milk, the survival rate of the PDL cells can last up to 6 hours. That's why we consider milk as also a physiological medium. So we have HPSS and milk considered as a physiological storage medium. Anything other than these two is considered as non-physiological medium. Next medium is Viaspan. You would have seen all this in films where the organs are being commonly transported by using Viaspan. The pH and the osmolality is very close to the ideal requirements, but the problem is that it's very costly and it is not readily available. Next is saliva. If the patient is not able to place the tooth back into the socket based upon your instruction, then they can even place it on the vestibule. Though this is not very effective, this can be considered, and for at least 1 hour they can bring the tooth being placed in the vestibule or in the saliva, and they can report to the clinic within 1 hour. And this can damage the cells of the periodontal ligament if it is being stored for a longer period of time. Next is propolis. This is a natural product which is produced by the honeybee in the resin tree. The advantage is that it's antibacterial and anti-inflammatory, and it's also antioxidant. Next is coconut water. This is technically called as a liquid endosperm of the coconut, and it is the safest and the natural soft drink which is available. We commonly use this for replacement fluids and electrolyte. This can be even used as a transport medium. Next is saline. though saline lacks the minerals, that is magnesium, calcium, and glucose, this can be used for a very short period of time. That is within 1 hour. If they report, saline can also be used. Since it is isotonic in nature, this will not allow for a normal metabolic needs of the PDL cells. Next, the last will be the tap water. This is readily available, but it is an hypotonic medium, so that this in turn will cause rapid cellular lysis. The PDL cells will start to die. It is almost similar to like that is being stored dry. So thereby, I end my session on avulsion. So far, I have discussed about what is avulsion, what to do immediately if the patient is calling you, and then I've started saying about the steps or the various measures if based upon the conditions: open apex, closed apex, 5 timings, and storage mediums. Then we proceeded on to the splinting, various splintings, and we saw a few videos, and then we ended up with the various storage medium. Thereby I conclude my session. Thank you all for your patient listening. Thank you.